Welcome, and thank you for joining us in this pre-recorded breakout session for the HSR UK Network Conference from the 1st to the 3rd of July 2020. This is a new concept and format for the conference, and we hope that you enjoy the session. My name is Usha Boolaky, and I am the Assistant Director for Research at the Health Foundation. I'm pleased to be hosting this important session on improving equality, diversity and inclusion in health services research. And I'm joined by my colleague, Charli, Colegate, who is supporting us as we record the session and who will also manage the Q&A discussion at the end. This session was originally designed to be really interactive, to explore the challenges we all face in promoting diversity and inclusion in health services research. We wanted to share our learning with the wider community and bring together a range of perspectives so that we could explore some of the opportunities for us in improving diversity and inclusion. Could I have the next slide, Charli? With a move to a virtual conference, we've had to change the format of the session. We now have about 60 minutes to discuss the importance of diversity and inclusion in health services research and share our experiences and reflections with you. We want to explore the experience of people who are typically left out of the research process or who experience structural barriers to participation, and share some of our insights on what we're learning about developing more inclusive, diverse and participatory research practices. In order to make this session as participatory as possible at short notice, we began to gather people's questions using the HSR UK cross-inclusion hashtag prior to recording. Do feel free to continue to use this to carry on the conversation beyond the session. We'd love to hear from you, and particularly what has worked and where you think we could be doing more as a network to support this important agenda. Next slide, Charli. I'm really pleased to be joined today by a range of speakers, each with their own perspectives on the issue of diversity and inclusion in health services research. Rather than me introduce everybody individually, I've asked them to introduce themselves and just to give you a little taste of why equality, diversity and inclusion in research is so important to them. So over to you, Ollie, maybe you could start.
Yes, hello everyone. I'm Ollie Williams, so I'm a postdoc fellow at King's College London, funded by the Healthcare Improvement Studies Institute. My background is in health inequalities, and I suppose that's the reason why I'm so interested in these issues or passionate about these issues, is because I think fundamentally a lot of the time where policy about reducing health inequalities doesn't end up reducing them in practice is because we don't include people and talk to people, and we don't have a diverse range of people involved in that decision making and making those things happen. So I'm currently studying a 3-year project about the role of co-production within patient and public involvement in health services research. And a guiding question within that is, when is co-production not co-production? And I'll go through some of those things today.
Lovely, thank you. Emily, can I pass over to you to introduce yourself and Kerrie as well?
Cool. So I'm Emily Niner. I'm the participation manager at Ambitious About Autism, and that means that I work with autistic young people aged 16 to 25 across England in a range of participatory projects, including participatory research projects. Equality, diversity and inclusion in health services research, or research in general, is really important to me because I see the effects of research not being relatable to the young people that I work with. And when you consistently see research or opinions or information about your life that isn't relatable, it can be very, very frustrating. And so that's why we do the work that we do at Ambitious. I'm going to pass over to Kerrie.
Hi, my name is Kerrie Portman. I'm in my first year of university and I have autism. I volunteer with Ambitious About Autism, and we've currently been working on a collaboration project between Ambitious and Creary into the education of autistic students following the 2014 Children's and Families Act. Because I have autism, what's kind of been said about us in an academic way is very impactful on my life, so it's something that's very important to me.
Lovely, thank you. And finally, Natalie.
Hi everyone, so I'm Natalie, I'm the director from Black Thrive. So our work really looks at how we address mental health inequality. I'm also have an academic kind of background, so have been part of the kind of sort of been part of that kind of knowledge production process, and I've kind of been sort of acutely aware of the bias that we weave into our research. And so I'm really kind of keen to, for us as kind of academics, people working in this space, to really think about how we could work differently to make research more inclusive, and so that it can actually be applied in practice to really make a difference in people's lives.
Lovely, thank you everybody, and I look forward to hearing more. So Charli, next slide, that would be lovely, thank you. So why is this topic so important, and why now? I think it's fair to say that there's no unifying definition of health services research, largely because it's inherently multidisciplinary and spans a range of different aspects of healthcare policy and delivery. But one of the things that most definitions of health services research have in common is the role of research in understanding the impact of healthcare on individuals and populations, with the aim of influencing policy and practice and improving outcomes for people who over time. However, in order to be able to do this well, we need to be able to understand the diversity of experiences and views across different settings and capture and record those in our research. Otherwise, we only ever see a fraction of the overall picture and build support which fails to meet the needs of particular groups or individuals within society when they are at their most vulnerable. Over the past 10 to 15 years, there's been a greater push for more inclusive practice in the way services are co-created with patients, and more awareness of the issues around inequalities experienced by NHS staff from a wide variety of backgrounds. These have led to a number of initiatives like the Workforce Race Equality Standard, person-centred care, and an increased focus on co-production in service design and delivery. While there may still be clearly more to be done within the actual health service itself, one of the challenges we've observed as a funder and a research organisation at the Health Foundation is the lack of diversity within both the health services research community and the things which are funded. And we've become increasingly aware that the way that we frame research to be more inclusive needs to be more inclusive in its practices, so that we can really understand what is happening and why, and what mechanisms we can use to improve health and healthcare across the UK. At the Foundation, we've begun a programme of work looking at both our own internal arrangements for improving diversity and inclusion, and also how we support it through our funding mechanisms, and how we can use our influence to move this agenda forward within the research community, some of which I'll be sharing today in terms of our early thinking and work in this area. I think it's fair to say that when we originally devised this session, we knew this was an important issue. We knew that people across the UK were experiencing poorer health outcomes often, and those people were also the ones that experience the worst care or have less access to the opportunities which support good health, such as good housing, proper education and work. We also knew that in many places across England, these inequalities were widening, and that in some places this progress was in fact in decline, as demonstrated in our recent work with the Institute of Health Equity in its report, the Marmot Review 10 years on. And despite all the efforts that funders and researchers have been making, we're still not capturing data or information on the people who are experiencing the biggest health inequalities of all. I think it's also fair to say that when we originally devised this session, one of the things that we didn't know was that the impact of health inequalities would be so starkly revealed by the COVID-19 outbreak, which has highlighted huge gaps and structural issues in our level of knowledge about the most marginalised communities in the UK. Nor could we contemplate how rapid the research response would need to be in order to fill some of these gaps in knowledge, so that we could understand the extent to which different people experience health and healthcare, and how fragile some of the services and support in place for people at the margins of society really are. Moreover, and actually somewhat concerningly at the time we're recording this, COVID-19 is also beginning to highlight deep and entrenched bias and structural issues in the organisations which fund, support and host research, and inequities amongst groups of researchers and research institutions. Charli, could we have the next slide? Thank you. Oh, 2 seconds. So this really begs the question of how do you respond to these challenges? How do we dial up diversity and inclusion in health services research from a funder's perspective? There is surprisingly little evidence out there on what steps funders can actually take to improve diversity and inclusion in research, and what does exist is often highly contested, something that Ollie will pick up on in his presentation. But as funders, we also know that issues with diversity and inclusion occur at all points within the research system, from the application processes which preclude people with disabilities from applying, or short turnaround times over things like school holidays, which can often prevent primary carers from submitting. We know there's a lack of support and mentorship and guidance for minority ethnic researchers who support them as they start out in their career, and a lack of job security stopping people from translating often graduate or postgraduate studies into full-time research careers. We also know that there is a significant gap between the knowledge produced by research and the settings in which it can have the most impact, with little involvement of users of research in its translation. We're still also seeing a power imbalance between researchers and people with lived experience, and a hierarchy of evidence which often prevents narrative testimonies from filling the gaps in our knowledge. And commissioning panels are often recruited based on their track record rather than the breadth and depth of experience that they bring. Indeed, we're even seeing in funding conversations where we bring in patient and public representatives that we often choose to go with our usual contacts, who are often referred to as people who are professional representatives and have had experience of the research process before, in the name of expediency rather than providing and pursuing broader representation from the communities we're trying to support. But we can make significant progress if we want to, particularly through targeted interventions, such as the progress made by NIHR in the uptake of the Athena Swan programme and the Involve team, and the shifts in grant conditions to allow part-time and flexible working and better support for applicants with additional needs. So I think it's fair to say at the Health Foundation, we're trialling a number of different approaches to try and improve diversity and inclusion, from internships through to undergraduate placements and fellowships. We're broadening our commissioning panels and indeed have over 75% representation from the sector and people with lived experience sitting on one at the moment. We've developed things like easy read core materials where appropriate to try and engage more people with the research that we're funding, and increasingly are using deliberative processes at the start of our research commissioning process to bring together a range of different views on what matters most in both assessing our research agenda but also in the interpretation of our findings. 2 years ago, we set up our Young People's Panel to inform our Young Persons Inquiry, and we're also in the process of scoping an inclusion panel as we start to do more work on health inequalities. Through this institute, we've also funded a large-scale citizen science platform to develop collaborative and participatory projects with the NHS, and we're currently using this to support rapid research in response to COVID-19. We've also heavily invested in our Q community to try and bring together practitioners and clinicians and to help them and support them to access the best evidence available in relation to healthcare improvement. For us, it's still really early days and we need to review and monitor and evaluate our impact as we go along. But what is really clear from all of this is that if we are to see a step change in diversity and inclusion in health services research, we need to be proactive as a funder about setting this agenda. We can't leave it entirely to our award holders to drive this change, and we need to be braver about doing things a little bit differently, to be sure that we're learning from what works and what doesn't, and to work with our research communities to understand the barriers which stop them from tackling this in the research that they do. Next slide, Charlie. Finally, I want to leave you with some broader thoughts based on quotes from people far greater than me. I think we need to accept that research is formalised curiosity. It is poking and prying with a purpose. As researchers, if we want to be able to describe what's happening in health services research, we need to be curious about the totality of people's experiences. We need to ask questions across a whole range of different experiences to understand what is happening and why. Because if we don't ask the right questions, we don't collect the right data. And if we're not collecting the right data, then we don't know what we don't know, and we continue to compound inequalities. We need to be curious about the inequalities and the mechanisms which are causing them, rather than through bias or neglect, allowing them not to exist. And fundamentally, we need to do this if we want to ensure that our research has impact and to reduce research waste, because collecting and understanding diverse perspectives helps to develop better discussions and lead to better outcomes for everyone. Thank you. I am going to pass over to Ollie now.
Thanks for that, Usha. And it's a pleasure to be part of this session. And although Usha's just said that she's not as esteemed as those people, it's really great that she's brought together everyone in this session. And it's great to be working with the Health Foundation, who seem to be taking this issue very seriously. So, as I said in my introduction, I'm currently conducting a project that principally is trying to answer the question, when is co-production not co-production? And in some ways, this seems like a simple question, but it's actually quite difficult to answer, because depending on who you are and what background you have, and what literature you've read, you may have a different answer on what co-production is and therefore what it's doing. And I suppose so the guiding question for this presentation is, will co-production promote equality, diversity and inclusion in health services research? And to spoil the ending, essentially in short, it could, but it certainly isn't inevitable that it will. So this makes sense because asking this question at the core of it, I suppose, is in recent years we've had co-production certainly within patient and public involvement, elevated to this kind of status as a gold standard of patient and public involvement, that goal production is something to be aspiring to and trying to achieve. But there's a number of issues with this. In part, I'm not sure how useful it is to have gold standards or one gold standard in anything, particularly not in this line of work. But beyond that, the term co-production is itself contested. It has different histories, and it has different understandings, and different people use it in different ways. So the definitions and the rationales that we have for co-production will lead to different destinations in terms of what it can achieve or what we're trying to achieve with it. So here I've just outlined 3 definitions and 2 rationales, or what we might say are primary motivations for co-production. So these are all in the literature. This isn't an exhaustive list of definitions, but some that I've come across as I've been doing this research. So the first definition that we might have, and this is what we might say the more classic one, is that co-production was a word brought in, often it's credited to Eleanor Ostrom, who noticed when she was studying the police department in Chicago, that services in different areas in the city were more or less effective depending on how involved people in that community were in providing the service. So in some sense, how do you reduce crime in an area? If people put locks on their doors, if people are vigilant about reporting crime, if they're willing to talk to the police, all of those things are part of the police being able to do their work. So in that sense, you coined the term that these services are co-produced, in the sense that the service itself is inevitably co-produced. It has a two-way process. And I think that's quite key, is that traditionally we had thought about services being delivered in a one-way process. You have a service provider giving a service. And this idea of co-production was this idea that services are always co-produced. If you think about going to a bank, for instance, and you have to cash some money, you've had to count it up into the little bags and you give it over. So you're doing something in that process. So it's recognizing that services are inherently co-produced. And there's also a branch of literature that looks at this in terms of knowledge production, so from science and technology studies. So again, this notion prior, that the idea was that knowledge was created by people. Certain people have certain ideas, and particularly it's normally white European academics who have these ideas. Whereas this co-production of knowledge, the idea is much more that, you know, we're all standing on the shoulder of the giants. There's no idea that is isolated from any other idea. So all of these things are emerged. So that knowledge is in itself inherently co-produced. So on this one level, we've got this sense that things are co-produced by their nature. Then we have another understanding, and I'd say this is very, very common in health services research particularly, is that co-production is essentially a synonym for collaboration. And this is the one where I'd say that the idea of co-production as a bit of a buzzword is certainly legitimate. So the reason we're now talking about co-production rather than collaboration is because we know that funders are interested in this term. It's something that funders want to see. But the problem with this definition is that only sometimes are we talking about collaboration with patients or people from the public, citizens. So sometimes when people are using this, or I'd say normally when people are using this notion of co-production, they're talking about mainly producing things between academics and what we might say health professionals or people that work in industry. And patients and service users may only be partly involved in that or not involved in that at all. And then this is that you get to see why that is maybe, or I would say certainly problematic when we move on to this third definition, where co-production is understood as a means for radical power sharing to promote equity. So it's this idea of recognizing that there are various inequalities in power and influence, and that co-production is a way of trying to bring different people into decision-making processes who are normally excluded or marginalized within those processes, with the aim of making something more diverse, more inclusive, and more fair or more equal. And then, so if we move from definitions onto rationales or primary motivations, we could say that there's kind of two main ways of the motivations people have for doing this. So there's a technocratic rationale. So that would be that, and this is one commonly rehearsed by researchers, that the point of co-producing something is to make your work better. So, you know, if you want to design a service, it makes sense to involve the people who are going to use that service, because they'll be able to tell you what their needs are and what their preferences are, and therefore you can design a service to meet those needs. So it will make things better. And that this is normally motivated by the idea that we want to close this gap between research and practice. So we want to make research that's implementable, and that can, and therefore research can have an impact. And then this other rationale, which we might say is more broadly a notion of democratic rationale, which again, so it's about fairness, it's about trying to include people, it's about trying to break down those unequal power structures. But it's also motivated by a similar need, and that creating things that are fit for purpose, but that they also have equitable outcomes, so that they're addressing what we could say are fundamental inequalities in a system. Now, it's important to stress that these rationales, and indeed some of the definitions, are not incompatible, but they're not always complementary. So people might have a real desire to involve people for technocratic reasons, but they've got no real desire to make things fairer or more equal, for instance. And therefore, co-production won't inherently promote equality, inclusion, and equality. And diversity, sorry. Charlie, can we go on to the next slide, please? So if co-production is to promote equality, diversity, inclusion, and health research, then I would argue that these principles need to be central to what we define and practice as co-production. So I was recently involved in writing a paper about co-production and what we might understand it to be, or what we might aim for it to be within health services research. And there's this quote from it, which I think is particularly useful in this discussion. So I'll read it at length. So, inherent to co-producing research is bringing together patients, service users, or marginalized citizens with researchers and professionals or practitioners, and attempting to form equitable partnerships. This extends to patients, service users, or marginalized citizens, making meaningful contributions to agenda setting and the formation of research questions, not merely being involved once these important decisions have been made by those who traditionally hold power in research settings. This draws otherwise excluded perspectives and understandings into the strategic and procedural decision-making processes. And one of the things that's really exciting about this session that we have today is that, as you will hear in the presentations that follow, this is what some organisations are already doing. And what's particularly interesting for me is that neither of those organisations really use co-production as a defining term to describe what they're doing. So in that sense, some things are being called co-production, which I would say probably aren't co-production. Some things that are definitely what I would say are co-production aren't even using that to describe themselves as what that is. And I think it's important to focus at this point that we can't just talk about what's good or bad practice. We need to also think about context. So Charlie, can I have the next slide, please? So in this regard, it's helpful to think of co-production as a living organism, like a tree, for instance, that's capable of producing many fruits, many different things. We can get lots of different things from it, but its capacity to thrive is reliant on its surroundings, like most things in nature. So Charlie, can we go to the next slide? What's important then to recognise is that the structures of research have tended not to be conducive to promoting or supporting co-production beyond perhaps theory. So this is why we see lots of articulation of co-production in strategy and in policy, but not necessarily lots of co-production in practice. because things like the difficulties of trying to get funding to do this work, the difficulties of trying to get managers to allow you the time and the funds to do this sort of work, the expectations on researchers that we have certain metrics for success, which this work doesn't always easily fall within. All of these things are quite difficult to the process of co-production. And if we want co-production to be part of what we're doing, we need to think about these structures and how conducive they are to promoting co-production. Charlie, can we have the next slide? And so lastly then, what I'd say is what we need to recognise, and this is what's really promising about talking to Usha, and particularly what they're trying to do at the Health Foundation, is that if we want research to be co-produced, and if we really want co-production to promote equality, diversity, and inclusion, we need to start to change some of the structures that we have, and we need to get rid of some of the traditions perhaps that we've had in research. So there both needs to be modification and sort of moving away from certain ways of doing things. And if we do that, I think that there is real possibility for co-production to promote equality, diversity, and inclusion. If we don't do that, and if we have different understandings of what co-production is, then I would suggest that it could just support the status quo, essentially. So yeah, thanks for listening.
Thank you, Ollie. That was great. Emily and Kerrie, can we pass over to you?
Please may I have our first slide, Charlie? So as perfect, as previously mentioned, I'm Emily Niner and I'm the participation manager at Ambitious About Autism. So we are a national charity for autistic children and young people, and the team that I run, we work on participatory projects. So we have our youth council, and then we have actually 8 streams of other work at the moment on different projects that are led by young people across England. So their priorities have been in recent years: mental health, exclusion from education, loneliness, employment, and equitable access to youth groups, things that they're quite often isolated from. Next slide. So what I wanted to do is give you a really quick background around the health inequalities faced by autistic people, a brief overview of some projects that we've been working on, and then I want to hand over to Kerrie because I think her experience is much more important. So statistics are pretty bleak, actually, and it's something that not many people know about and that people are quite shocked at. So 71% of autistic children and young people have a mental health condition, and this will most likely continue into adulthood. And I probably should have started by saying that official statistics are around 1 in 100 people are autistic in the UK, so around 700,000 people. Autistic life expectancy is 54 years instead of 70, and this was a Swedish study with controls, and the leading causes of death are suicide and epilepsy. So around 3 in 10 autistic people are also epileptic, and the leading cause of death being suicide obviously links quite closely to the stats we have on mental health conditions there. These are the results of health inequalities and barriers to healthcare for autistic people. So 54% of autistic patients say that phoning the GP is a barrier, and 75% of patients feel misunderstood by their doctor because they're autistic. Now, we've done lots of work around this, and there are tools out there and there is training out there, and the Royal College of GPs have autism champions, but it's not filtering down, and so we're still finding again and again that autistic people aren't accessing healthcare through the primary point, so through primary healthcare, and that's our point down in the bottom right there. So for many autistic people, emergency services are their first point of entry on the healthcare pathway. So this could be through mental health crisis, or this could be through A&E, and this may be because they have not accessed primary care, and so something has reached a really extreme level, or because they find it easier to access that way because there's less barriers. You can walk in rather than having to ring up. Next slide. So some of the research projects that we've been working on have been led by and are based on the priorities of the young people that we work with. So Research in general around autism is very medically focused. It's focused on biology and genes and causes, and this is not reflective of the priorities of the autistic community. The research charity Autistica, who obviously this is their domain, have done research into the community's priorities, and only 27% of UK research money was spent on the top 10 community priorities. The number one priority for the community is mental health, followed closely by support or social care for adults, because quite often people think of autism just as autistic children and don't think about the fact that autistic people grow up. So one of the first research projects we ever did was Know Your Normal, and this was a unanimous decision by our youth council. They wanted to focus on mental health because they knew that it was something that was affecting them and their autistic peers. So it was collaboration between them and UCL, the Centre for Research in Autism and Education, and the youth patrons designed the research, they designed the questions, they designed the whole project. And what they did as well is, what I think is really important, is they then translated that. So they made a shorter document that broke down the research project so that it was actually accessible. And they also made a toolkit. So this toolkit is about being able to map what your normal is, because what they found is when they went to the doctor would conflate autism and mental health or suggest that it was inevitable. So this toolkit is something you can fill in and say, well, actually at my normal, I sleep 7 hours a night, but at the moment I'm only managing 4, and my normal is focusing on my special interests or hanging out with my friends. At the moment I have no interest in any of those things. So actually having something tangible to show. Know Your Normal has a global reach. It's really exciting, actually. It's been taken on board by the Canadian government and also is being used across Queensland in Australia. It's reached some interesting places. So that was Know Your Normal, and then from that, that was an award-winning project, and I think people really liked that project because they could see that it worked, that actually involving young people was important and made it more authentic, but that it worked, and that it resulted in something that was actually useful. So Kerrie will talk a little bit about this project, but Post-16 Young Researchers, this again is a collaboration between Creary and us, and it's research into the impact of the Children and Families Act on education for autistic students. That will be completed shortly, and that's been led by a group of 4 great young researchers. Next slide. And finally, which is probably, and it's ongoing and full transparency, is funded by the Health Foundation, is a project about improving access to and experiences of healthcare for autistic patients. So off the back of Know Your Normal, we realised that the healthcare pathway for autistic people is all over the place. It's different for everyone. It doesn't follow the typical journey that people expect. And so we wanted to look at we've been working in the Whittington Hospital in North London, and we wanted to see what was going on there, what was happening in different wards, the consistency of knowledge across different areas in the hospital, what people knew about autism, what people thought they knew about autism, and whether they actually had any sort of tangible or practical strategies they could put in place to help better support autistic patients. So this project is led by a health panel of 10 autistic young people from across North London who are service users. Some of them are actually also working in the Whittington, so we've got double experience there. And not only have they co-produced resources to support patient advocacy and support healthcare professionals, they've also designed a research project. So what they wanted to find out was a survey of healthcare professionals across the trust. What did they know about autism? What did they want to know? Had they ever had training? Because we found in an initial one that about 50% hadn't. A survey of autistic patients and those who support them, an audit of patient experience data, incidents and complaints. So this was really important. They wanted to know whether people were complaining about their care, whether they knew that they could complain about their care, and whether the steps that were being taken to improve it, if any were. And then the result of this, what we're planning, and obviously this is on hold at the moment, is facilitated communities of practice by our health panel and by us with health professionals across the trust. So what we wanted to do, we don't want to punish people for not knowing about autism. They wouldn't necessarily know, and they're not given the training at the moment. Obviously they're developing mandatory training at the moment. But we want it to be much more open and honest. So come to us and say, I had a really bad clinic this morning and I upset this young person, they had a meltdown, but I want to know why, what can I do? Rather than there being shame around it. We want there to be an open discussion, and then our health panel can say, well, for me this would have been beneficial, or you could look into this. So that's what we're working on at the moment. And now I'm going to move to talk to Kerrie about her experience, and we're going to go through 5 questions. So question 1, Kerrie, is why do you think it's important that autistic people are involved in research about autism?
People who don't have autism can't fully know what it's like, so all research would benefit from own voices input. It feels really different reading research when autistic people are involved and when we're not. And I think that for someone who's not fully involved in the research field, that shouldn't come across. Including us gives us a voice in what's being said about us, which helps empower us and reduce stigma. While autistic people want to participate, there's no reason not to include us. If research included autistic people, it might be more focused on helping us and not just focusing on the cause like it does currently. For example, autism doesn't inherently lead to poor mental health, but it's a very common co-condition, like Emily said, and suicide is a leading cause of death for us.
Cool. Question 2. So you alluded to it a little bit there, Kerrie. The majority of autism research focuses on the biology or causes. Why is this problematic in your opinion?
Priorities aren't the same between the autistic community and research. It's still mostly focused on the cause. I think focusing on cause over support ties into the anti-vaxxers who decide to risk their children's health and not vaccinate them out of fear they'll get autism, though that's properly disproven now. It's very sad that people would rather risk their kids' lives than have an autistic child. And I think that stigma extends outside of the family dynamic. I think finding the cause of autism implies a need for a cure. Currently, the most likely cause is genetics. And the way that's phrased, as an autistic woman, I often feel like that's implying that I shouldn't have kids because there's a good chance that I'll pass on my autism, which I think that the decision to have kids is a very personal one, and I think it's not really anyone else's place to say that I shouldn't have kids because I have a disability.
So question 3, what have you learned from taking part in a research project?
I've learned a lot of specific and more general things during the research. The ones that stuck with me most are how many autistic people said it took just one adult to put in the extra effort to improve their lives, education, and inspire them. The emotional impact of being denied help, how demotivating it is not to even have your voice heard. And I think also another resounding message was everybody has something to say to contribute to research, though the terminology can put people off and feel too academic.
Yeah, so that's a discussion we had about even the word research can seem really formal, and actually just asking opinions and discussing things with people is research. So question 4, what do you think the challenges are to supporting autistic people to take part in research?
I think there are challenges, but I think that most of the way to resolve those challenges are around being accessible and willing to adapt. Sometimes people think autistic people can't join in because they assume that we're stupid or lack capacity, but making general assumptions like that is lazy on the researcher's part.
Yeah, and the final question, what stereotypes do you think persist around autism that may shape someone's approach to research?
Autism is a very large spectrum that covers a lot of needs and abilities, and I think stereotyping ignores that variety. People often assume autistic people, especially non-verbal and selective mute people, have low intelligence, but not speaking isn't the same as not understanding. Another common stereotype is that autistic people don't have empathy. I read recently about research that looked into 2 different types of empathy, One where a person can predict the emotions of the other person and then respond to that empathetically, and the other one where the person responds empathetically once being told how the other person feels. While neurotypical people or non-autistic people are often better than the first, autistic people are often very good at the latter, and some people think that autistic people are actually more empathetic than neurotypical people in the latter variety.
And you said before, Kerrie, that made you feel better because you'd been told or had read about yourself for a long time where they'd suggested that you weren't empathetic.
Yeah, I was actually told, I used to be selective mute until I was 18, and I was actually told by a social care professional that I didn't have empathy and that made me a horrible person. And I thought that was really confusing at the time because I felt that I did have empathy for my understanding of empathy, but it was like a professional telling me I didn't, and that was really confusing for a long time. I do struggle a lot to be able to guess people's emotions, so often I only look for very basic signals, like if a person's crying, I'll know they're sad, but if they have more subtle facial expressions, then I won't necessarily know that. But once I know a person's sad, then I really care, and I kind of try and think of whatever I can to make them feel better. So that kind of research made me feel a lot better because even though I knew that I had empathy, being told that I didn't really impacted me and kind of made me doubt whether I did or didn't.
So I think that's probably a perfect example for us to end on, the fact that for 18 years, Kerrie, research around autism had suggested to Kerrie that she didn't have empathy, and how that can impact on your sense of self and your understanding of your diagnosis and of your identity. And so what we really need to think about, and what researchers need to think about, is who is their research benefiting? Is it benefiting the autistic community and those who support them? Or is it benefiting large research grants and results that will never be translated into anything that supports the day-to-day lives of autistic people? Thank you.
Thank you, Emily and Kerrie. I don't think there's any way I could sum that up any better, so thank you. And last but absolutely not least, handing over to Natalie to talk a little bit about her experiences through Black Thrive. Thank you.
So I've been asked to speak a little bit about the role of knowledge production. So as I mentioned in the introduction, I'm the director of Black Thrive, and we take a systems approach to address mental health inequality for Black people in the London Borough of Lambeth. We're a partnership that brings together local communities, the statutory sector, and also the voluntary sector to look at how we can look at the system in order to make fundamental shifts that will improve the outcomes for Black people locally. So our work is underpinned by the collective impact model, and this basically assumes that when dealing with complex or what sometimes is described as wicked problems, it requires all actors within a system to work together to align their agendas and focus their energies and resources to create the shifts that are required in order to improve outcomes. So we seek to influence mindsets, policy and practice, and we see that the knowledge production process is a key component in addressing inequalities that are experienced by Black communities. Next slide. So what does the research currently tell us about Black communities? And I thought it would be helpful to sort of have a very basic sort of definition of what we mean by knowledge production. And so for us, at the very basic level, knowledge production is the process by which we seek to either reaffirm what we already know or to create new knowledge, which will essentially become universal. So when we're looking at the research that's on Black communities, what's really quite interesting is that we are either hypervisible or invisible. The poor mental health outcomes of Black communities is well documented. We tend to experience greater barriers in terms of accessing services. Our experiences of services are generally much poorer, and we're more likely to enter the mental health system through more coercive routes, whether that be through the criminal justice system or being sectioned under the Mental Health Act. But what's really quite interesting is that these findings are seldom explained nor understood from a structural perspective. Little attention is paid to Black people's experiences of discrimination and how this impacts on their health and well-being outcomes. And in particular around mental health, the literature seems to be kind of preoccupied with exploring psychosis. So when we also kind of start to challenge ourselves, when we explore the literature further, and then we want to understand outcomes and experiences of Black people from an intersectional perspective. So for example, being Black and gay, being an older Black person or a Black person from socioeconomic groups, the literature is very, very sparse in that regard. And what we also find is that we lean quite heavily on knowledge that's produced in the States, because in particular in a UK context, the USA appear to be more advanced in exploring the experiences of Black communities. And I suppose in summary, I would say that the literature is very good at describing the problem and not so good at identifying solutions. There's also an issue that a lot of this research is produced through a Eurocentric lens. And that in itself is quite problematic, because it can mean that researchers overlook the nuances of the Black experience, and therefore the knowledge that what we come to understand doesn't really enable us to develop the kind of interventions that are, necessary in order to improve outcomes for Black people. And also, I think less attention is paid to how the research reinforces stereotypes and oppressive structures. Next slide, Charlie. So a lot of the problems within knowledge production and what it is that we have come to know is structural in nature. Often built on assumptions, and then there's also this hierarchy of knowledge, which is particularly unhelpful, especially in a context where very little is known about a topic. And this is one of the barriers that we experience in our work, that when we put forward solutions that have come from communities, we're often challenged to look at the evidence base. But actually, if it hasn't been something that has been important to those who fund this research, or for those who are researching the topic, we're not able to provide that evidence. So for us, we try to influence and kind of disrupt this process. And so for us, it's really important that we increase the representation of Black people in research. And lots of organisations like ours support researchers to recruit participants. But for us, we feel that it's important to kind of take this work much further. And so we seek to develop strategic partnerships with academics. And one of our most recent partnerships is with King's College London, with their new ESRC Centre for Society and Mental Health. And these partnerships are not necessarily as equitable all the time, not like the one that we've developed with KCL, where we are involved in kind of shaping the focus of their research. And so what we find is that because we are in a sort of attractive, fundable proposition, that at times we're approached by researchers and other organisations to kind of collaborate on funding bids. But our involvement is generally very tokenistic, and we're expected to work on their terms, even if it's evident that their approach is unlikely to lead to the outcomes that they're trying to achieve, and also when at times the approach that they're taking is likely to reinforce inequalities or potentially kind of structurally racist. So for us, it's really important that if you are, or organisations are interested in working with organisations like ours, that actually we pay attention to the power dynamic that exists within that research process. In terms of with our work, another important element is around engaging with researchers and institutions in conversations about racism and how it manifests itself in the research process. And without having those honest conversations, it's very unlikely that we will ever produce research that is truly inclusive and equitable. And for us, another part of our work that's really important, we see that we need to be active contributors to that knowledge base. And so we do this by conducting our own research. And for us, it's also important that we involve members of the community to be part of that sort of research process. And so we have people who are from the community who are trained to conduct research within their own communities. Next slide. So an example of some of the work that we have done most recently has been around exploring Black communities' experiences of the COVID-19 pandemic. And to do this, we trained a group of local people from the community as researchers. They're supporting us around doing a literature review in terms of kind of understanding what literature is already out there. They've been involved in designing a survey that has been that we've had over sort of 450 responses to so far, and they've also been out in the community conducting semi-structured interviews, trying to capture the stories sort of firsthand, so that we can have a better understanding of how Black communities are experiencing the pandemic, and we're using this knowledge also to help shape service provision and the recovery plans that the local authority and other statutory providers are working on at the moment. And a key important part for us is that they are also involved not only just in terms of collecting the data, but also as being involved in the analysis and also that interpretation of that data, because what we've identified through our work is that they often bring insight that may not necessarily have been obvious in the first instance. And moving forward, they'll also be involved in kind of co-creating the resources that we produce, and being involved in the dissemination of the findings. And I think an important question that we have to ask us is, who has ownership of those research outputs? And ordinarily, it would be the researcher. And so for us, it's again really critical that people in the community have ownership of the research outputs. And one of the ways that we do that is to ensure that they are named authors on any journal articles that we produce. Next slide. So what are some of the steps that you could take to make knowledge more equitable and inclusive? So based on our learning, it's really important that you involve communities, not just in shaping your research, but also kind of leading it. So that may be around shaping the focus of your research agenda. So at times it may mean that you are looking at things that may not necessarily have been in your plan, but actually the richness of having them involved in that process will mean that your work is more likely to be translatable into the real world. And another key area to pay attention to is, where are the resources flowing? So when you're applying for funding, what proportion of that money is actually going to local communities? And I think we need to get beyond looking at or making the assumption that just by virtue of producing the knowledge that actually communities are going to benefit from this. So if we are paying for our principal researchers, and we are not valuing the inputs of communities in a similar way, that does raise some concerns around how equitable that process is. I think in terms of the methodology, communities can be really, really helpful in helping to shape your methodology so that you are able to both recruit and retain participants within your study. And we have found that involving them in the data collection and also the analysis of the data brings a richness that we wouldn't ordinarily be able to bring because of the lens that we are kind of looking at the work. And again, in terms of dissemination and sharing the learning, it's so important that communities become, they are the experts on their experience. And so we need to make sure at the end of the process, they are the real experts on the experience, and that's not just capitalized by the few. So I guess one of the questions that we should be asking ourselves is, what have you, communities and partners have to gain? And if that isn't equitable, then we need to make some changes in order to make sure that everybody has some way of benefiting from the research process.
Thank you ever so much, Natalie and Ollie and Emily and Kerrie. I think that's been an absolutely brilliant session, and thank you for sharing your insights in terms of the research process. I'm going to hand over to Charli now to take us through the question and answer session. Just to say that some of these questions have been crowdsourced prior to this session being recorded using the HSR UK Cross Inclusion hashtag. Please do feel free to use that again after you've viewed this session, and do post questions for all of us. We're really happy to take those as we go on. We see this very much as being the start of a conversation with the health services research community, and not just being a single session on its own. Charli, over to you.
Thanks, Usha. Yeah, that was a really interesting and exciting discussion, and I certainly learned a hell of a lot from all of the speakers. In lieu of a live audience, we've been using Twitter and other platforms to source questions to put to our panel. If people, as we go through the discussion, as they're watching the video, they want to participate in what we're saying here, we'd encourage you to use the hashtag HSRUKXinclusion, which hopefully you can see on the slide there as well. So the first question that I wanted to start with is, so one of the challenges with more inclusive research is that researchers can often bring their own experiences to the table when they're interpreting findings and results. And I think, Natalie, you started to touch on it towards the end of your presentation there, where you're talking about people and communities being involved in the analysis and interpretation of results. But a question that I wanted to put to the panel is, how can we reduce the impact of researchers' biases to ensure that the experiences of communities that researchers are working with are better reflected in their work?
So if I sort of chime in here, I think what's really important is for reflexive practice, so that it's actually not just about kind of reaching our hands out to, or arms out to kind of communities to kind of encourage them to work with us, but for researchers to sort of familiarise themselves with anti-racist practice and principles and other forms of anti-discriminatory practice, for them to really understand the assumptions and the biases that they bring to the research, because this work is lifelong, and we really need to get more comfortable with having these uncomfortable conversations if we're going to make progress, essentially. And we need to do that as well as working with communities to analyse the data and to be part of that process of interpretation. But I think that bias is will always exist within the research process, but we need to be able to call it out and to actually think about it from a structural perspective in terms of, with this knowledge, you know, the way in which I go about trying to collect it, how am I reinforcing structural barriers, but also how I interpret it and share it, you know, how may I inadvertently do that too. And I think by working more sort of collaboratively with communities, we'll be able to address that.
Yeah. Thank you, Natalie.
Can I add to some of Natalie's response on some of that? So I think there's also a bit of a question about how much we value it in the research process at the moment. And I think Ollie touched on it in his presentation, that quite often, you know, co-production is added because funders are asking for it. And actually, I think there's a number of things that we can do to improve how much we value this notion of inclusion within research. I think one, funders can really interrogate applications properly and thoroughly to actually discover whether or not co-production is something which is really happening and why it's happening and how that really filters into the application and research process. Natalie has some beautiful anecdotes about kind of power imbalances in the application process, which are both incredibly frustrating but also very enlightening if you ever have a chance to have a conversation with her over it. And then there's something also about teaching the value of it. And I think one of the things that I'm not seeing, particularly within undergraduate and postgraduate curricula, is the notion of co-production as a process in itself. We teach a lot about methods, we teach a lot about interpretation, we teach a lot about things like writing and analysis skills, but actually we don't really talk about the softer side of research, and some of the things that perhaps as researchers we can do is actually raise awareness of it, and some of the issues around inequalities much earlier in the actual education of future researchers. So I don't think there's a magic bullet to this, but I do think there is more that we could be doing and bringing forward in terms of the agenda if we were more aware of it in kind of the whole of the system, not just the bits that we all individually see.
Emily.
So I'll go and then Ollie. So just adding to Usha's answer about values there, I think we need to ensure that the researchers both value the process and understand the process and are open to learning about the process. We have lots of people, I have lots of people come to me and say, I'd love to talk to your autistic young people. One, they think I'll say yes immediately and answer on their behalf. And I'm always like, well, no, I'll go to them and say, is anyone interested in this? Would you like to do it? And two, how long that can take. Remuneration, like Natalie said. So do you have budget for this, or are you just wanting to say, I spoke to an autistic person? And also valuing us as facilitators. Quite often they will use us as, one, they think we're a charity and so they don't have to pay. They're like, you're a charity, you do things for charitable aims. But they will try and use the charity to get to that pool of people, not respecting the fact that, you know, there are ways of facilitating these things, and actually some of our young people might want support and they might want us to be with them and work through it together. And also thinking about whether they do actually value the people involved. So again, what I said at the end of our presentation about who is this research benefiting, because if they don't actually value autistic people and their lives, and we've spoken about this before about kind of what is a meaningful life, if you're looking for genetics and biology, do you actually value the life of an autistic person and the life that they want to lead or choose to lead? And so, yeah, just breaking down all of that. So I will always interrogate someone when they come to me and say, I would like to work with your young people, but ensuring that they understand that and they're open to learning as well, because I think quite often they can be very defensive and say, you know, well, I'm doing this because I'm a researcher and you know, I need your help, but they're not actually thinking about how it could be translated to actually support and improve people's lives.
Thank you, Ollie.
Yeah, I suppose just picking up on what Emily said there straight away, and then I'll go back to the broader conversation, is that I think that part of the problem there is about organisations like Natalie's and Emily's often get used by researchers as a means to recruit people for their studies, rather than as a way of starting conversations with communities that they are wanting to understand what's important to these communities, what research should we do with these communities, what are the focuses, what are the priorities that we can learn from these communities. So I think that's an awkward middle step that we're in now, because I think that there's an increasing awareness that researchers shouldn't just be doing all the research, that the research is just done by people in universities. But the awkward middle step then is, I think, that often outside organisations like charities and not-for-profit organisations tend to get used as a way to recruit people, but not necessarily in a particularly meaningful or participatory way. To go back to the broader conversation, I think, like what Natalie said is completely correct. I think that biases is always going to be there, and I'd say that in the social sciences and qualitative research, we've acknowledged that for a long time now, that you can't get rid of these biases, you have to acknowledge them. And once you acknowledge them, you need to go a step further and to try and put things in place that help you to mitigate the potentially negative impacts of those biases. And that's, for me, the why that it's so important to be involving people early on, to be having conversations with communities, because it allows you to sort of check some of those biases that you may have. And to go to Usha's point, I think that in terms of what funders can do, I still think it's incredible, really, but I think it's an indication of how seriously something like co-production is taken seriously, is that most funders now will expect you to involve people, and that they say that their gold standard would be co-production, and that it will explicitly state that that means that people who aren't researchers should be involved right from the beginning of projects all the way through. And yet there are not many funders who have an open call for involving people in the creation of research projects, the creation of research applications. So researchers are often in a difficult position where the funding structures mean that they have to essentially get people involved with no money at all at the beginning, in the hope that they might get funded, and then once they've got funding, try and make it more participatory. But by that point, you've already set research questions, you've already set priorities, and some of the biases have already come in. So I think what funders need to do more, if they're serious about this stuff, is to have pools of funding that researchers can go to and say, I want to go and talk to this community, because there seems to be a neglect of this community. They seem to be marginalised in particular ways. There's probably priorities there that we're not hitting. So can I have some money, please, to go and work with these people? And not just for researchers to do that, for outside organisations to go to those pools of funding and say, we want to work with universities to do this work. And I think until we see funders put in that sort of resource, I don't think that we're going to get really co-produced projects.
Thank you, Ollie. I'll move on to the next question now. So this was a question which came in from Dr. Michael Brady via Twitter, who I believe is National Advisor for LGBT Health. So LGBT individuals experience a wide range of inequalities in outcomes, experience, and access to care as well, yet are rarely represented in clinical research. How can we address this with either LGBT-specific research or better inclusion in more general healthcare research? What are people's views on that?
I think that while the challenges that face LGBT people are different than those that face the autistic community, I think the same themes of person-centered care, treating people like people, and adaptation are the same for most minority groups. Around 50% of autistic women identify as LGBTQ+. So I think there's a lot of intersectionality there.
Good, thank you, Kerrie.
And I think that there needs to be space for both. So I think that research generally needs to become more inclusive and to pay greater attention to people's social identities in all their forms. But I think that it's also important that there is research that is specific to the experiences of LGBT communities and at the intersections. And I think this is also something that we see in our work with Black communities. We find that kind of generic studies pay very little attention to, ethnicity and the or race. So that would actually be really helpful for us to kind of understand the experiences when we're kind of segmenting communities, in that way. But similarly, there is also a need to do research that is focused on the experiences of marginalised communities.
I think from a funder's perspective, just to pick up on both Kerrie and Natalie's points, I think one of the challenges that structurally the funding community struggle with is that you have what I would call generic large funders who fund across a host of different issues and research questions like the big government funders, the Health Foundation, etc. And then you have specific charities who will fund related to their very specific charitable aims around things like particularly marginalised groups or particular disease conditions, etc. And one of the things that I don't think we've cracked yet, particularly the big sort of general funders who fund across a range of different topics and themes and research questions, is how you drive the research agenda to really capture some of those issues around inclusion and inequalities. And one of the things that we're trying to do at the Health Foundation, and it may not be a perfect fit by any stretch of the imagination, is to really think about how we bring those voices into the research agenda setting process. And to really think about actually how do we use depth and breadth of experience from beyond the research community to really try and understand what might be some of the challenges. And you know, all our panels at the moment across funders tend to be driven mainly by the academic sector itself. You know, you have the experts in the room. You may have one or two people with lived experience in a room, but one or two people with lived experience in the room cannot demonstrate the entirety of the population's experience. And I think we need to really think about how we're engaging people in setting those agendas more effectively. And I think we have to go beyond one-off big deliberative exercises. They play a role and they are an important part of it, to being able to generate more ongoing conversations so that we can understand some of the nuance around some of these challenges.
Yeah, and I think that what's key in that then is that, as we've spoken about before, there are partnerships that can be formed with smaller groups, and there are partnerships that can be formed with charities. And as Emily was talking about, that as an organisation, they really do want to work with researchers. The point at which researchers come to them for collaboration, I think, is really important, and it would be the same for LGBTQ communities in that sense of, you don't just want a researcher to come to you and say, can I have some people who identify with a marginalised sexuality? You want a long-term partnership so you can find out from a breadth of people what are the important issues, or on a particular issue, what are the different viewpoints that people within that community have. And I think that with LGBTQ in particular, that's a very diverse community, and in the same way that BAME gets put together, it's that these things are only packaged together because it's easier to put all of those minorities together, but they may be as different as they are. And so when I worked in Leicester, a common stat that was put around was that in Leicester was one of the places where white people were, one of the first cities where white people were a minority in comparison, but that was based on stats that white people compared to all of the other ethnic groups that existed within Leicester. And once you start to think about that and appreciate that, you understand why there's a real problem there, because it's kind of normal against all of these other things abnormal, and you think, well, that's really, really problematic to think in those terms. So I think we need to recognize how diverse communities are that we work with, and a lot of the time recognize when we use the term community that it might not be a community. Often we talk about patient communities, but those patients might not feel that they're in a community at all. Actually, one of the defining characteristics may be loneliness. I think that's interesting. To people talk about loneliness communities, like there's the inherent irony there. So there's diversity. So one of the ways you can work with lots of people in ways that are reasonable is to work with organisations who are in touch with lots of those people, so that they can tell you about different opinions, different views, different experiences within those groupings. So my point being that it's important to form like long-term, genuine partnerships with organisations who may have their ear to the ground that you haven't got.
Thank you. And just to add to that, specifically focused on the LGBT individuals and community questions. So I'm sort of what the role for funders might be. So in 2017, I had the opportunity while I was working at the Wellcome Trust in their social science and humanities research funding team to work on a call around sexuality and health, and sexuality as a context and determinant of health. And working on that call, we got around 300 applications. So we were only able to fund 10 projects, but I think that really demonstrates and shows how much interest in that particular area there is out there. So that was funding research in the humanities and social science as opposed to clinical research, but the funding it provided was seed funding, so to develop methods and to build relationships with particular communities as well, with the idea that they would then submit a larger application for funding in the future. And the issue that you talked about, Ollie, there about lumping kind of particular groups together under acronyms was something that a few members of that cohort of 10 projects that they have picked up in a publication as well that I can link to in the description of this video too. So just to move on to our next question. This is a question for Kerrie and Emily. So what do you think are the most important research questions related to autism? So earlier you mentioned that Autisticus work said that mental health and support for social care for adults was top priorities in work that they've done. But from your perspective, what do you think the most important research questions are to be answered?
I think the overarching question should be, how can we improve the quality of life for autistic people? And there are a lot of individual questions within that, but I think that should be like the umbrella question. And I think the main things about getting more autistic people involved in research is being accessible in both language and in the actual research.
Yeah, so I think Kerrie raises a really valid point about improving the lives of autistic people. As I mentioned before, Autistica do look at the community's research priorities, which I think is really important. And I would agree personally that with their number one, which is mental health, and looking into the experience of mental health conditions by autistic people. I found it interesting earlier when Natalie said that Black people are more likely to enter the mental health system through coercive means, and that's very similar with the autistic community. And I think it's really important to look at mental health and include autistic people in that conversation, because at the moment they are disproportionately affected by mental health conditions. And as Kerrie said, it's not inevitable. And actually, by not acknowledging that, it's incredibly dangerous. It's not just frustrating for autistic people not to be involved, it's dangerous because autistic people and those with learning disabilities are much more likely to be in ATUs, so assessment and treatment units, and there's not that much kind of focus given to that, and the fact that there are lots and lots of autistic people in solitary confinement, in horrendous situations currently. And I also think that another priority should be looking into how we can improve healthcare and social care for autistic people. I think everyone is aware, they probably don't think about it, of lots of the social care scandals, so things like Winterbourne View and Walton Hall, and the abuse cases against autistic people and those with learning disabilities. And unfortunately, the COVID-19 pandemic has just highlighted those again. So there are excess, I hate the term excess deaths, but there are excess deaths in the autistic and learning disabled community at the moment. And they actually, the most recent thing I read, they believe that only 40% are COVID related. So of the rest of them, there are suggestions that it's probably neglect and other unexplained reasons. And the thing is, those deaths were very unlikely to be investigated. So we're letting down this entire community of people, letting them die early for unknown reasons, and there's very little being done about it. So yes, looking into mental health and then also health and social care. And I know I keep talking about it, but the idea of meaningful life and what is valued, because we've also seen in the past few months a 30% increase in do not resuscitate orders on autistic and learning disabled people without consultation, just being blanketed across care homes and residential settings. And so really looking into that and working out why this community is not, their lives aren't valued as much as everyone else. Yeah.
To add to what Emily was saying about the social care part, because as well as having autism, I grew up in care, so I was kind of raised by the social care system. And sometimes I've seen a lot of inequalities within that. I know that they're more being talked about and they're more apparent with the current COVID-19 situation. And I think there probably is an increase, or I know there's an increase in the neglect, but I think there's a lot of issues within social care with autism generally. I think one of the things I've noticed from my personal experience, and I've heard a lot of other people speak about it as well, is that most social care settings aren't trained in autism. So they'll kind of look at a behaviour and they won't necessarily understand it, and then because they don't understand it, a lot of people, I'm not saying everyone, but a lot of people take a almost aggressive approach because they feel so defensive they can't understand it. For example, there's something called stimming, which a lot of autistic people do, and it's kind of a way, when there's like a lot going on, it's kind of a way to self-soothe yourself. And essentially stimming is repeating a form of sensation seeking, so it might be rocking or making quiet noise, but it's essentially a harmless way to self-soothe that looks very odd to people who don't understand it. And I know especially in social care, a lot of people see that behaviour, they don't understand it, and they take a very aggressive and violent, sometimes even, approach, which obviously makes the situation worse, because if you're doing something to try and calm down and people get quite aggressive, then that obviously makes it worse, and then it's kind of a big cycle. So I think for my personal experience, I've noticed equality in health and social care, but I've noticed a more aggressive approach within social care than within healthcare. I think that's a big issue still.
Right, thank you, Kerrie. So I think maybe moving on to my final question, and it's we're talking about COVID-19. Natalie, are you able to share any early stage findings of Black Thrive's COVID-19 research? And in light of what you found, what do you see as the most important COVID-19 related research priorities for the Black community?
So through the research that our community researchers have kind of captured, and through the survey, we've identified that there is a distrust of the government, and there was sort of quite a lot of concerns about the way in which I suppose information has been communicated about COVID. So for us there is a real need for kind of clearer communication and kind of engagement with communities, and the need for transparency. Isolation is an issue, but I think one of the things that we sort of pulled through that actually it means very different things for different people, and so for some, a kind of being in isolation hasn't felt as bad, but for others it has had a quite significant impact on their mental well-being. There is also kind of issues or challenges around kind of digital access and inclusion, and so you know, people having experiences of kind of needing to move online but not necessarily having the skills to be able to access online facilities, because it's not something that they've been historically familiar with, or not necessarily having access to devices, you know, internet access, data, that sort of thing. And I think there is some uncertainty, I suppose, in terms of what the future means for them, I guess, in terms of COVID-19 having magnified some of the issues that have already, that already existed. And I think that that is something that you know, is being kind of discussed and more broadly. And again, in terms of around like jobs and kind of income security, you know, there are some issues and kind of concerns around what that means. So for many Black people, some Black people, not necessarily many Black people, but some of the measures that have been put in, many of them are kind of falling through the cracks. So in terms of the relief around kind of mortgages, well, actually for Black communities, they tend to have lower home ownership rates than their white counterparts, and are more likely to be in rented accommodation. So that kind of places a strain, and for people who may have been insecurely housed and maybe sort of staying with people, with lockdown it became more difficult for them to find places to stay because people were concerned about COVID transmission. So I think if we're thinking about what we need to focus on, I guess for us it's very common to look at the disadvantage from a perspective of it not being not looking at it from an asset perspective. So one of the things that came through our research was actually there is a real resilience within the Black community, and so I think that's something that shouldn't be lost when we're exploring the experiences of Black communities. And I think that there needs to be focus on people from Black communities actually leading on shaping the research agenda, but also kind of conducting the research. Oh, sorry, one more thing. Sorry. And the other thing is actually the focus needs to be looking at not just exploring the explanations from a biological perspective, because that means that we then stop focusing on the structural issues. And I think, as I highlighted earlier on in my presentation, that it's very easy to describe the problem, but we need to understand it in the context of the structural barriers that Black communities experience.
That's great. Thank you, Natalie. I'm going to wrap up the Q&A there, if that's all right with everybody, but then give our speakers an opportunity to say any final comments before we finish.
Yep. Did you want me to go first? And are we? Yeah,
go ahead, Usha.
So I've actually got 2 points I just really wanted to add to the conversation. I think it's been really rich today, and thank you all of you for participating, because I realised that we sort of invited you and it's been an awful lot of work to get to today. So I think really the thing that strikes me listening to everybody talk today is that the opposite of inclusion is exclusion, and the issues that we've been talking about have been here forever in the system. I think the current situation with COVID-19 has shown these up in stark relief. You can't avoid them. But I think as funders and as researchers and people who are participating in research, we need to make sure that these are issues that we are continuing to address, not just in the current situation, where people have suddenly become very interested in health inequalities and the impact on the AME population, for example. And I think we need to be doing much more to be capturing the views of people who are at the margins of society, and that perhaps don't share the same lens as us when we're going through our research process. And then my final sort of reflection on today and more broadly around this agenda is that I go into a lot of conversations with funders, both as a partner, as somebody who goes in to explore interesting conversations around research topics and themes. If in 5 years' time I'm going into those conversations and nobody is saying, oh, it's too difficult to engage, it's too difficult to include, they're hard to reach communities, then I think we'll have seen a step change. At the moment, it is still too easy for us to be able to step back and go, do you know what? It's not important to engage people in the shaping of research agendas. It's okay to do it at the margins of our research protocols, and it's okay just to try and shoehorn it into a method and an idea that we've already had. And I really, really want us to see some change in that, so that people have got a real equality of opportunity to participate and also to set the research agenda and where we invest our funding.
Thank you, Usha. Ollie, do you want to go next?
Yeah, just adding on to what Usha, well, firstly to say thanks to Usha for bringing all of this. Usha contacted all of us individually and brought us all together, and has done a great deal to sort of make this session happen. And it's so, I suppose, buoying to work with someone who clearly wants to make things change, because research environments are often fairly resistant to change, and so it's really great to be working with someone who wants to make that happen. I would add on to the opposite of inclusion being exclusion. I think in terms of to achieve some of the things that Usha wants to achieve, it's not just to see that it's exclusion, but then to understand or analyze that as being injustice and unethical. So in research, we have an ethical duty to ensure that our research is ethical, and that shouldn't just apply to individual projects, but the agendas that we set, and therefore excluding vast populations, and particularly, say, as Natalie was talking about earlier, and Emily, about the impact that this has had, COVID has had, and has demonstrated these inequalities, then you have to see it as unethical to exclude these groups from the research process. So in terms of my interest with co-production, I think the important thing there needs to become, how do we move away from co-production being this buzzword that is now included into funding applications as a way of trying to secure funds, people playing the game of the funding game, which every academic is forced to do in part through the insecurity that is in the employment sector, the employment nature of academia. So how do we get away from doing that? And I think it's about trying to understand, okay, when you say co-production, it's fine. If you mean just co-production in the sense of collaboration, fine, but that has to be explicit. I think the real problem at the minute we've got is that people use the term co-production to suggest that their projects are more inclusive, more diverse than they actually are. And I think that is a really big problem. So sure, it's a contested term, but it's how are we using that term? And therefore there's a lack of legitimacy if some people are using it to suggest that they're doing more than they actually are.
Thank you. Emily, Kerrie, do you have any final reflections?
Kerrie, would you like to go first?
I just wanted to say thank you for having me. And then I also wanted to re-emphasize the point about how I think that while a lot of minority groups might have specific struggles in terms of reaching them, including them within research, I think that like adapting to the needs of that group is kind of the most important, as well as, you know, kind of just treating people like people and, you know, genuinely wanting to hear from them and hear what's important to them.
Yeah, I think I would just echo exactly what Kerrie said there. So it isn't hard to adapt. You just need to be willing and open and actually listen. So don't ask if you're not willing to listen to the answer and then act upon it. And I also think there needs, as well as involving more autistic people in research, we need to promote more autistic researchers. And so Autistica, I don't work for them, but I've shouted them out twice. But they have awards for autistic researchers, and I think that's really important to emphasize and promote as well, because without having autistic people in academia, it will suffer as a result. So yes, adapt, be willing to listen, and promote autistic researchers.
Thank you, Emily. And Natalie, finally, on to you.
So for me, I think that I suppose everybody who has some involvement in the research process, there is an opportunity for us to feed into the social justice agenda. And so I think it's for each of us to think about what is it within our gift that we can do to remove the structural barriers that make it difficult for Black people to be seen in research, but also that also makes it difficult for Black people to live their lives because of the narratives that are being shared within the research. So I think that that is something that we really kind of need to reflect on. I think if we want to work more closely and collaboratively with kind of Black communities, that actually similar to what has already been said, is that it's to approach this work with humility. So yes, you may bring your expertise as the researcher, but actually the lived experience will bring a richness to the work that you probably wouldn't realise if you were doing this on your own. And I think, again, I think what's also really important is for us to actually invest in Black researchers to be able to do work on their own communities, or not on, but with their communities more appropriately. Because again, in my own research, when I was researching the experiences of Black and mixed race communities, I was reading research on my own community, but I couldn't see myself within it. And that actually the literature that I was looking at that resonated with me were often by researchers, without even looking them up, were often by researchers who shared similar social identities to myself. So I think there is something about being able to encourage and to support researchers from the communities that they are, that they're researching. So again, and that's also a structural issue, because if you look at it from the experiences of Black communities in the education system, they experience kind of greater sort of barriers in relation to the education system. They're less likely to get access to institutions that are considered to be prestigious. When we look at where research funding goes, that tends to go to kind of Russell Group universities, where there isn't generally much representation from Black, Asian or other minority ethnic groups. So again, we need to think about it from a structural perspective as funders. Who are you funding? If you're only funding Russell Group organisations, then it means those opportunities for students who are probably generally from Black, Asian or other minority ethnic groups are not necessarily going to have that opportunity to get involved as research assistants, on these types of programmes. So again, there are things in our gift that we can do differently in order to make the whole research process more equitable.
Thank you very much, Natalie. I'd like to bring us to a close now. And I hope that you have enjoyed this, and please continue the conversation using the hashtag HSRUK inclusion. Thank you, everyone.